Okay, welcome everybody. It is Friday, February 6th, 2026. We're here for another Florida EMS webinar, and we have a great one scheduled for you today. First, before I go into that, I want to just thank everybody who joined us this past week in the NAEMSP 2026 annual conference in Tampa. Because it was in Florida, we had just a tremendous Florida showing. Our chapter meeting was standing room only. Our dinner was brimming at the seams. We filled every one of the 90 seats. Very grateful to Zoll, Trauma Gel, and Intersurgical for sponsoring a great night. We had keynote speakers, Tanner. We had people talking about pediatric CPAP. We had people speaking about Trauma Gel. It was really fun. And so what I wanted to do this week is bring in two people who won awards at NAEMSP. And these two people won awards for best abstract presentations. And you know them very well. One is Tanner Smida, my co-host here on the show. And someone else who's become really part of the family here to the Florida EMS webinar, Ian Drennan. Ian, you can see his extensive bio there on the screen, but basically a flight medic, critical care medic. That's 50% of his brain, but the other half of the brain is he's a PhD. He's a research scientist, specifically in cardiac arrest. He works closely with our good friend Shel Cheskis up in Canada. He's on ILCOR. He's on the AHA. He's level-headed, brilliant. And for those of you who are interested in Florida, we're going to be connecting Ian into our systems here so that we could potentially collaborate on research with Ian, because Florida is really becoming the epicenter of EMS in this country. And so just thank you all for that. So without any further ado, Ian, if you wouldn't mind making any further introductions, and then what you're going to be presenting is the award-winning presentation that you gave at NAEMSP. And take it away, my friend. Thanks for joining us.
Amazing. Thanks, Peter. Thanks for the kind words and having me on the webinar to present today. Morning, everybody. Like Peter said, my name's Ian. I'm from Toronto. I wish I was down in Florida again. It's absolutely freezing in Toronto right now, but to be expected at this time of year. But yeah, it's my pleasure to give the same presentation that we gave at NAEMSP. Really looking at a secondary analysis from the dose VF trial. Let's see here. No financial disclosures related to this talk. Like Peter said, I do a bunch of work with ILCOR and AHA, and grateful for Peter for still having me on here, even though I do work with some of the guideline organizations as well. So I'm sure everybody's familiar with the dose VF study that was published by Sheldon and others a couple of years ago, looking at the alternative defibrillation strategies for refractory VF. I'm not going to get into the details of it, but just to remind people that the primary secondary outcomes from that study showed that both a double sequential and vector change defibrillation were superior to standard defibrillation in terms of survival to hospital discharge and across a number of secondary outcomes within that trial and secondary analyses within that trial. But one of the things that kind of remained post-trial was really, why did we see this significant benefit from these alternative defibrillation strategies, and what might be the actual mechanism of action behind double sequential and behind vector change defibrillation? So we published a number of studies looking at some of these different potential theoretical mechanisms behind why we felt double sequential defibrillation might be superior to standard defibrillation. But one of the things that we have yet to kind of explore is in terms of mechanism, is around current delivery and impedance between the two different pad placements. And so what we wanted to look at, what we wanted to look at in this study was we wanted to look to see if there were differences that could be explained between the two pad placements in terms of current delivered to the heart and impedance to that might be impacting that current itself. And the reason why we felt this was an important mechanism that needed to be explored was because of some observations that we saw very consistently throughout the DOSE-VF trial. And this is just an example of one of the cases that we looked at. Looking at the impedance, you can see in the, just to highlight the circled area up there, you can see the impedance from each of the shocks that are delivered. And so as we go through this case, what you'll notice is a significant drop in impedance when we switch pad positioning. And of course, if you drop the impedance to current delivery, you're going to get more current that actually ends up defibrillating the myocardium and potentially mechanism for better shock success. So this is the first shock of a DOSE-VF trial. This would be an anterior lateral shock position. You can see the impedance about 100. Look at shock 2, same thing, anterior lateral, about 100. You can see the shock's joules increasing. The impedance stays very consistent across each of these non-intervention shocks in anterior lateral pad position. And then you start getting into the shocks where we started doing double sequential. So this is the first shock, same patient, first shock, and this is the double sequential shock at shock number 4. So you can see in the first shock, which again is anterior lateral pad position, you can see the impedance, again, very consistent with the first 3. But then when you did the anterior posterior pad, or the second part of the double sequential shock, what we see very consistently throughout the trial is a pretty significant drop in impedance, about 30% or so, and this happened in multiple different cases. And so we thought, well, if we're dropping impedance, potentially that's what's offering this beneficial effect that we saw with those different pad placements. And so there's been other studies that have explored the relationship between shock current and defibrillation success. But what we wanted to do, in fact, we had a good opportunity to do with DOSE-VF because of the data that we've collected, is to look at current and pad position, so the vector of that current, the amount of current, and defibrillation success, which we measured as return of spontaneous circulation. So the primary objective of this secondary study was to determine whether changes in shock current were associated with improvements in ROSC, and then to determine whether changes in pad position were associated with improvements in ROSC. So, like I said, it was a secondary analysis of the DOSE-VF RCT. We had all the variables already except for weight. We went back and abstracted patient weight, estimated by paramedics in the field, as a potential confounder for obviously current delivery and shock success. We had some formulas that were provided by us by our defibrillator manufacturer partners, which allowed us to calculate the current delivery because each one calculates current delivery slightly differently. And we calculated out the mean current over the first 6 milliseconds, which allowed us to standardize the amount of time of current delivery across the different manufacturers. So we were kind of making it, comparing apples to apples instead of comparing 2 totally different waveforms in terms of current delivery. We also were able to report energy. We reported current and impedance from each of the manufacturers. And then we limited our calculation to the first 6 shocks, which would be 3 non-interventional shocks, which allowed you to get enrolled into the DOSE-VF study, and then 3 interventional shocks as well. So our primary analysis was that we compared the probability of ROSC between AP and AL pad positions in relation to shock current. Interestingly, after doing a bit of an exploratory analysis on the double sequential cases, we actually decided that we had to exclude them specifically from this analysis. And the reason we had to exclude them was because it became clear very quickly that it was really impossible to determine how those shocks were interacting in terms of actual current delivery. Would you sum them together? Do you average them out? And either way that we looked at them, it was very hard to determine. So we excluded them to get a more clean picture of anterior-posterior versus anterior-lateral pad position. We did multivariable regression for each of our interventional shocks, 4 to 6, and ROSC was our outcome of interest. We then did a secondary analysis where we looked at the association between current and shock type, including all of the interventional shocks, so shock 4 to 6 in a single model. And because when you have multiple shocks within a single patient, those don't get to be independent analyses anymore. And so we used a GEE model to account for that non-independent relationship between the different shocks. So what did we actually find? So we had 405 patients from the DOSE-VF study. We used 355 of these, or ended up with 342 in this analysis, based on that kind of per protocol population. We analyzed about 1,800 different shocks and about 850 interventional shocks that were included in this final analysis. And so what we found when we first looked at just kind of that raw energy and the current delivery, so you can see the shock number 1, 2, 3, those were all non-interventional shocks. Those were all anterior lateral. And then you can see shock 4, 5, and 6, which would be our interventional shocks. And so what you can see in the highlighted area is that very consistently across all those anterior lateral pad positions, the impedance to current delivery was very consistent at around 90 to 94 ohms. And then when you look at the current delivery, you can again see fairly consistent around 16 amps or so. But what happens when you see the anterior pad position or AP pad position, you can see that there's a very consistent, substantial, probably about a 25 to 30% drop in impedance and an increase in current. And that was very consistent across the board. So when we looked at the probability of ROSC, so here you can see the probability of ROSC across the range of current that was provided. The blue line is the anterior pad position, and the red line is the anterior lateral pad position. And so when we did our multivariable regression models for shock 4, 5, and 6, which were the interventional shocks, very consistently across all current delivery, the anterior pad position resulted in a higher probability of ROSC than the anterior lateral pad position. And so it was interesting that the pad position was more predictive of ROSC than the actual current that was delivered itself. And in each of our models, current delivery was actually non-significant, which was a bit of a surprising finding. When we look at the GEE model, so this is, again, we took all shock 4, 5, and 6, and we threw them all into the same model. And did a regression model with that. Again, you can see that the anterior posterior pad position was significantly associated with higher probability of ROSC than anterior lateral pad position. And again, interestingly, current delivery or increasing current delivery was not. So what did we think this means from a research perspective or clinical perspective? Well, the mean current was greater across the AP pad position than the AL, regardless of manufacturers. And the pad position, but not current in this specific study, was associated with increased probability of ROSC. We didn't find any interactions. We did some interactions that I didn't present looking between current and pad position. And all of this sort of suggests to us that the current path, and not just the current value or even opposed to the current value, is a critical factor for shock success. So potentially this is one of the, this might be an explanation of the findings of the DOSE-VF study, where we saw that vector change and double sequential both had an anterior posterior pad position or pad vector associated with them. And so we think that this may help to explain some of the findings that we found in the overall the parent trial. And so moving forward, what we think is current is important, but the path of current is likely critical for defibrillation success. Interestingly, each of the guideline organizations has a bit of a different take on what they think the right pad position is, but really there's actually no evidence to support most of what we know in terms of pad placement. And so research suggests that the anterior posterior pad is more effective in terms of vector, but what we really need is we need an RCT evidence to kind of back this up and to really give us some more evidence from superiority of anterior posterior compared to anterior lateral pad position. So there are some obvious limitations within every study. So, it's an observational study. So we're unable to precisely determine the total current delivered by the anterior, posterior, and anterior lateral shocks. And although it does come from RCTs, again, observational studies are mostly hypothesis generating. And so, there are some limitations with that. And really, are there other ways that we could have calculated out some of this current value to, again, give us a bit of a different take on the current itself? And of course, the body weights are estimates and something estimated by the paramedics in the field. So in conclusion, the current delivered in AP pad position was consistently greater than anterior lateral pad position. The ROSC was greater in the anterior pad position over multiple different interventional shocks and multiple different current ranges, over actually all current ranges. Pad position was independently associated with ROSC, where current was not. And so future research, I think we need to look at exactly how do we quantify the current delivered when we are actually using double sequential instead of just changing the pad position as well. And we need some future research really looking at this anterior posterior versus anterior lateral pad position strategy as an initial strategy for ventricular fibrillation, and to challenge this current dogma that we think that AL first strategy is better for out of hospital cardiac arrest. And that's it. And I'm not sure if we're doing questions there, Peter, or we can do questions at the end, but I'm happy to chat with you as well.
Let's do only because I want to make sure we get through everything because I have so many questions and But this is really an amazing presentation. Please save your questions for the end, or if people want to put them in the chat and Ian can start to answer them there. But I do want to move over to Tanner. So Tanner, we're going to stay with the cardiac arrest theme. And we have some great people on this call, so I definitely want to get to some questions afterwards. But Tanner, go ahead and share your screen and talk to us about another just really important topic. And congrats again to you, Ian, and to you, Tanner, for winning the awards for best abstracts. And just for those people who don't know, these abstracts have not been peer reviewed, they have not been published. But I'm assuming, Ian, that this is going to go to publication, and this paper should be out in give us a some time
It
frame.
it is under review currently, so yeah, I will put that in there as well. So
Okay,
hopefully published sometime soon.
perfect, awesome. All right, awesome. Thanks, Ian. Tanner, go ahead, my friend.
Sounds good. Good morning, everyone. And I'll give this just like I gave it at NEMSP as well, and I'll say that I first went to NEMSP in 2020, and since then we've seen a ton of mechanical CPR abstracts presented at that meeting. But today I'm going to be breaking that mold a little bit, and we're going to be comparing machine to machine in the context of pre-hospital resuscitation. So last year, I was tagging along with our institution's physician response unit, and we went to a local EMS agency for a quality improvement meeting, as we kind of do on a monthly basis. And at that agency, they just purchased new cardiac monitors, and the paramedics told us that they had some sales reps circling and making some extraordinary claims about the effectiveness of their company's mechanical CPR device. And so before they made any commitments and switched devices, they came to us and they asked, are there any data to actually support one device producing better outcomes than another? We thought this was a great question, right? So we have two devices that are primarily commercially available and used in the United States. They drive blood flow through slightly different mechanisms. So we have the band type devices that leverage more of the thoracic pump mechanism. We have these plunger type devices that deliver the sternal compressions with the piston that may provide some degree of active decompression, at least to the baseline, which may provide differential blood flow and differential outcomes. But when we looked at the literature, despite the fact that these devices have been used in the United States for decades and they've been used to treat hundreds of thousands of millions of patients worldwide, there's really not a lot of data directly comparing the outcomes produced by each of these devices. And so when we saw that, our team, they set their favorite grad student loose on the ESO Data Collaborative. And ESO is a software company, so they provide electronic health record software to EMS agencies all across the United States and more recently in Canada. And essentially all of the data that paramedics enter into an electronic health record is de-identified and made available on an annual basis, in addition to some hospital outcome data. So a subset of agencies, they participate in a bidirectional health data exchange. And so they have hospital outcome data available. So we included all adult non-traumatic cardiac arrests who received mechanical CPR. We excluded patients who had a cardiac arrest in a nursing home or assisted living facility, patients who were encountered during interfacility transports, as well as patients with advanced directives, so kind of some standard exclusion criteria. Our primary exposure was device type, and our primary outcome was pre-hospital ROSC, which we chose because it's time-stamped, it's available for everybody in our data set, and it's proximal to our exposure of interest. And we've talked a little bit about these on the webinar before. We use something called a directed acyclic graph to choose the covariables that we need to adjust for in our multivariable modeling strategy. What this essentially allows us to do is create a diagram that can kind of explicitly explain hypothesized causal relationships between clinical variables that exist and influence an exposure outcome relationship. And so they allow us not only to identify confounders that we need to adjust for, but also variables called colliders or mediators that we should not adjust for. And adjusting for these variables could actually bias our estimate of effect size. As one example, so if you're trying to assess the association between device type and survival, you might be tempted to adjust for something like duration of pre-hospital CPR in your model, right? We know that certainly predicts outcome following cardiac arrest. However, that would be inappropriate in the context of this relationship, because it might actually act as a mediator. So if you have two different device types and one provides better blood flow, that device is probably going to get ROSC more often, and it's probably going to get ROSC sooner, which is going to directly modify the duration of pre-hospital CPR, right? Decrease the ischemic burden of patients and improve outcomes. And so if you were to adjust for duration of pre-hospital CPR, you'd essentially adjust away any benefit along that causal path, and you might obscure a difference between groups that exists. And so after using that directed acyclic graph, we came up with this laundry list of covariables. We have some kind of clinical factors, some demographic factors, as well as some agency level covariables. So what is your EMS agency type? What proportion of your employees are volunteers? What's your geographic region? We enter those in a multi-level mixed effects logistic regression model. And this approach has several distinct advantages. So it allows us to address clustering at the agency level, right? So we have patients nested within agencies. This is important when you think about how this intervention is actually delivered. So patients are typically, or paramedics are typically not deciding at the patient level whether they use a plunger type or band type device on a day-to-day basis. Typically, their agency, their cluster, is picking a device, and then when it's time to deploy mechanical CPR, you just use the device that your agency has purchased. As opposed to kind of some standard one-to-one propensity score matching methodologies, it also allows us to use all available data. We don't have to discard any unmatched patients. So we looked at 3 years of data from ESO, encompassing about 400,000 out-of-hospital cardiac arrest patients. Of those, just under 40,000 met our eligibility criteria, and of our eligible cohort, about 10% or 4,000 patients were treated with band-type devices. This is a snippet of our table one. I include this just to illustrate that these groups were very similar at baseline. There's no matching here, there's no multivariable adjustment, but we still see identical median ages, weights, response times, similar proportion of presenting initial ECG rhythms, which kind of supports the nature of this analysis as a natural experiment. 24% of patients treated with plunger-type devices achieved ROSC in the pre-hospital setting, compared to only 22% of patients treated with band-type devices. After multivariable adjustment, this was statistically significant and translates to a number needed to treat of approximately 42. So that means, again, based on our estimate of effect size, we would need to treat 42 patients with a plunger-type device instead of a band-type device to get one more patient with pre-hospital ROSC. So very small estimate of effect size. To provide some comparison, so the Paramedic 2 trial that compared 1 milligram of epinephrine every 3 to 5 minutes to placebo suggested a number needed to treat of 4 to 5 for the same outcome. We then did a number of subgroup analyses in clinically relevant subgroups, and we found that essentially universally, all of these subgroup analyses, the point estimate favored plunger-type devices, although, of course, there was not universal statistical significance in these subgroups. Because of a concern that clinicians were classifying the rescue pump as a plunger-type mechanical CPR device, we did a subgroup analysis excluding those patients. We looked only at patients treated by agencies that used both devices at least once during the study period, likely because agencies either switched during the study period or agencies had multiple different first response agencies or fire departments within their first due area that used different mechanical CPR devices. And then finally, because the number of resuscitated cardiac arrests at an agency level may serve as a proxy for clinician experience with deploying devices and kind of with resuscitation in general, we added the number of resuscitated cardiac arrests during the study period at the agency level to our models. Once again, all of these subgroup analyses showed that plunger-type devices were associated with better outcomes than band-type devices. Now, we also realize that maybe pre-hospital ROSC isn't the best outcome. And we say that because operationally, many agencies were not deploying mechanical CPR devices to get ROSC, right? We're deploying these devices to facilitate transport when pre-hospital ACLS has failed, perhaps when we've identified a reversible cause, right, that can't be reversed in the pre-hospital setting, right? Maybe we have a patient in refractory VF that's failed double sequential, right, or failed vector change and needs ECMO. And so we deploy mechanical CPR devices in those settings, not to get ROSC, but to ensure effective perfusion during transport to definitive care. So when their reversible cause is addressed, they don't have an irreversible ischemic burden and can go on and survive with a good neurologic outcome. And so we attempted to address this within our data set by looking at the association between device type and survival in the subgroup of patients who are transported without ROSC and had survival to discharge data. We did not detect an association between device type and survival to discharge overall, or in kind of the subgroup of patients who presented with an initially shockable rhythm. Now, of course, kind of despite the efforts that we made to minimize common sources of bias in observational cardiac arrest research, um, our results are still subject to bias from residual confounding and unmeasured confounders, right? So one example is we didn't have access to CPR process metrics or monitor files. We weren't able to adjust for rate, depth, recoil, chest compression fraction, pauses, right? Things that could be modified by both mechanical CPR devices and could also influence outcomes. And so it's possible that the difference that we observed is mediated by some of these modifiable aspects of device application. Um, that said, right, normally I would say we need a randomized controlled trial to actually answer this question, right? We need prospective randomized data. And I think that is true. However, it is unclear if this is a question that would achieve priority with funding bodies or with trialists like Ian, right? And the reason for that is in order to detect this very small effect size in ROSC, just based on some back of the napkin math, we would have to enroll almost 10,000 out of hospital cardiac arrest patients, right? Spend millions of dollars, spend years and years of time and effort. And that's to detect, to even have a chance of detecting an effect size that is ROSC, right? It may not even be clinically relevant. And so I'll leave that there. So in conclusion, plunger type devices were associated with a small increase in the odds of achieving ROSC. We weren't able to discern a difference in mortality. And of course, residual and unmeasured confounding limit causal inference. And future research is needed to optimize the use of mechanical CPR in the United States and worldwide. Thank you.
Amazing. Tanner, do you only because I want to move on to the to segment three here. You want to go right into the other abstracts from the conference, and then we'll open it up at the end. There's a lot of great questions coming in. I think just as a take home point with an NNT of 42, no one should be changing their mechanical CPR devices. Like no one should be panicking, right?
Right. No, no, absolutely not. Yeah, and I think this is kind of a general point about observational data. It is very rare that we should be making any change in clinical practice based on one observational study alone, right?
Don't tell pals that, but go ahead.
Right. No, yeah, and I
Had
understand.
to say that. Yeah.
But personally, I feel like it's poor form to jump to any conclusions, right? And I think that this warrants further study, right? And larger databases that have neurologic outcome scoring, right? So we've submitted a proposal to CARES. They have these same data elements. So hopefully they approve our request so we can generate some more data to maybe better answer this question. So.
Excellent. So while Tanner's pulling up the next slide, what I asked him to do is to take just to give us some highlights of some abstracts that he felt were kind of at the top and some highlights there. So Tanner, take it away, and then we'll open it up for questions afterwards for both presenters.
Yeah, and so last year I sort of did a similar thing with the 2025 meeting abstracts, and I tried to follow kind of a similar format this year. I did try to stay away from, as I did last year, the oral abstracts that were presented, because they've kind of had their day in court. They've been able to present their research in front of the organization, and I instead tried to focus on some of the poster abstracts that were relegated kind of lower in the rankings, but that I found were really thought-provoking and interesting, and maybe in my opinion, I thought should have scored higher. So the first of these, and this is kind of a personal interest of mine, right? Maybe a lot of my personal biases you'll see kind of creep into my choices here. The first of these looks at the practice of transcutaneous pacing in the pre-hospital setting. This abstract comes from kind of the Seattle Medic One research program. And these authors essentially looked from 2017 to 2024. They looked at patients who received transcutaneous pacing within their kind of single center agency. They reviewed all of the cardiac monitor files, and they determined whether clinicians were actually achieving electrical capture, right? So for every pacer spike, they were looking to see whether that was followed by kind of a broad QRS and a T wave. And they did this with a kind of an extreme degree of granularity, right? So even within cases, they were able to determine within that individual case what proportion of these pacer spikes were followed by what their expert reviewers determined to be electrical capture. And so over that period, they identified 56 patients that were treated by Seattle Medic 1 and underwent transcutaneous pacing. And they found that in this exceptionally high performing system, right? These are the best of the best in the United States in terms of training and clinical practice. They found that they only achieved electrical capture ever in 32% of their sample. And they also had the luxury, in addition to monitor files, they had audio recordings for all of these cases. They were actually able to listen in on the cases to determine when the paramedics were palpating pulses and determining whether mechanical capture was present. And they found that reported pulse palpation only corresponded with electrical capture in 4 instances, so about 15% of the cases, right? And so I think that in this exceptionally high performing system, we all looked at this as kind of a beacon of high quality clinical care for cardiac arrest and other disease processes in the pre-hospital setting in the United States. This adds to the body of literature suggesting that we are not as good at pacing as we think we are, right? And even when we are unsuccessful at pacing, we are not recognizing that we are unsuccessful. And so I look forward to publication of this manuscript from these authors. Of course, it wouldn't be a NAEMSP without a ton of cardiac arrest manuscripts. And I've picked a kind of self-serving abstract here that includes both myself and Ian on the author list. I thought it was appropriate to include, given that both of us are here. So this was an ESO study that looked at adoption or use of double sequential defibrillation in the United States, both before and after publication of dose VF, right? So kind of asking the question, after publication of this randomized controlled trial that suggested there was a strong signal for efficacy, are people actually doing this, right? Are they implementing this into protocols at their EMS agencies? And so we looked at all adult patients in the ESO Data Collaborative from 2018 to 2024 who received at least 4 defibrillation attempts. And we kind of stratified this cohort by whether they were treated before or after dose VF. We segmented the cohort overall into quarters. We ended up with over 16,000 patients who were eligible for double sequential defibrillation based on our kind of crude definition. We found that overall, few eligible patients actually received this procedure. So about 7.6% received the procedure in the pre-hospital setting. After publication of dose VF, we did observe an increasing rate per quarter. So we detected what we would refer to as a slope change following publication of dose VF. And I think the main takeaway is that although use seems to be increasing, or the rate of adoption seems to be increasing, even in the quarter where we observed the most adoption, so Q4 2024, we're still seeing just over 10% of eligible patients getting this therapy. And so, again, there's some trials coming out that hopefully will confirm the large benefits that we're seeing in dose VF. But if we have an intervention here, it looks like we have an intervention with a number needed to treat for survival to discharge of somewhere around 5 or 6. If only 10% of eligible patients are getting this procedure, we have a lot of work to do in the United States on kind of the implementation science front. So of course, right, there were also a lot of papers or abstracts looking at the practice of pre-hospital advanced airway management. The first of these comes from the NAEMSP data set, looking at trends in supraglottic airway insertion at the basic life support level, right? So there are more and more states and more EMS agencies that are allowing EMTs and even EMRs to place supraglottic airways for cardiac arrest patients in the pre-hospital setting. So these authors essentially wanted to characterize this practice. So they looked at 911 responses that had a primary advanced airway attempt with a supraglottic airway. And then they stratified that cohort based on certification level. They evaluated just under 200,000 supraglottic airway placements. About 1 in 5 of these were placed by EMTs. And they found that about over 50% of agencies had at least one supraglottic airway inserted by an EMT in 2023. And so that just kind of goes to show how widespread this practice is. I certainly think that, given that the iGel, right, for instance, is certainly as easy to insert as an OPA, I think it's certainly reasonable to include this in the BLS scope of practice and encourage the placement of these supraglottic airways early in tiered systems where you have BLS clinicians arriving first on scene. There's plenty of data out there that suggests that we are very bad at bag valve mask ventilation, right? There's excessive leaks. A lot of times we're not delivering any tidal volumes at all. And so I think that supraglottic airways might be a way to kind of fill that gap and ensure that we're effectively ventilating cardiac arrest patients early in tiered systems. I really love this abstract. This might be my favorite abstract that didn't get an oral of the whole conference. In my opinion, this certainly should have got an oral presentation just based on methodology alone. And so this was a single center study. So they looked at data from a single metropolitan EMS agency. The system had transitioned from supraglottic airway management with a king laryngeal tube to the AirQ3 supraglottic airway device. And they looked at a couple different variables. So they looked at first pass success. And importantly, they didn't just look at whether paramedics or EMTs documented first pass success in the electronic health record. They actually looked at end-tidal CO2 data and said, okay, did you actually have a sustained four-phase waveform after placement? And then that's what they used to adjudicate first pass success. And then they also looked at subsequent failure. So there's some literature out there that suggests that, particularly the king laryngeal tube, we get unrecognized failure of these devices, right? So you get maybe cuff perforation on a tooth, right? That kind of loses the seal in the airway, or you get dislodgement of the airway. And so they looked at subsequent failure, again, using waveform capnography. So loss of that sustained four-phase waveform. And so they looked at over 2,000 patients treated with supraglottic airway devices. About 60% were treated with the AirQ, about 42% were treated with the King. They found that first pass success was slightly higher with the AirQ than the King, which would kind of align with previous data, like that our group has done looking at the iGel versus the King. And they also found a large difference between the AirQ and the King looking at subsequent airway failure. So the King failed much more often. So about 30% of the time, they were losing that four-phase waveform that was able to kind of adjudicate the fact that we were actually delivering effective ventilations to patients. They did some Bayesian analyses, right? So Jeff Jarvis was on this paper. So they found that there was a 40% probability of seeing at least a 5% higher first pass success with the AirQ, and a greater than 99% probability of having at least a 5% lower subsequent failure rate with the AirQ compared with the King, right? And so again, right, so using this kind of before and after methodology in this single system, using this kind of rigorous methodology, using waveform capnography data to determine both first pass success and subsequent failure. Beautiful abstract. Can't wait to read the paper. I think that this paper should have ranked much, much higher and certainly deserved at the very least an oral abstract, if not an award at this conference. Okay, so blood transfusion, right? So there were also a number of abstracts looking at the characteristics of patients who are getting blood transfusion from different ground agencies. And I thought this one was really interesting and pending the abstract manuscript coming out and being published, I think it could be really useful and inform system design. And so these authors, in again a kind of a single EMS system, they looked at MPDS codes, so emergency medical dispatch codes that were associated with blood transfusion, right? And so they identified some of the usual suspects, right? So gunshots to the trunk, right? A high mechanism, auto pedestrian injuries, auto versus motorcycle and bicycle accidents, cardiac arrests that were precipitated by a gunshot, right? Things that we might not necessarily be surprised to see, right? However, where I think that this is really innovative and really important is, we have all of these systems that are deploying blood in a supervisor vehicle, right? Or in a subset of ALS units. And so they're constantly having to make the decision at the time of dispatch, where do we send the blood, right? And for what calls do we actually pull the trigger at all, versus waiting for a crew on scene to confirm the need for blood, right, to actually deliver it, right? And we see in many systems that there are kind of missed opportunities to transfuse patients because, the need for transfusion is not recognized until someone arrives on scene, and then the hospital is closer than the nearest unit that carries blood, and maybe we had an opportunity to improve outcomes by just sending that blood in the first place, right? And so I think that these data provide scaffolding for future work to maybe develop algorithms that can automatically dispatch supervisor units or units that are carrying blood to calls that have a high priority of actually needing that resource. So really liked this one. And then I'll finish up with this abstract. I've kind of classified it as a miscellaneous subject material that looks at the role of physician oversight in high risk refusals. This is a large part of the job as a medical director, and I think it's also a scary part of the job that comes with a lot of medical legal risk. Is consulting with paramedics in the field, right? They call in, they say, hey, this patient wants to refuse. We think they should probably go to the hospital, but they're refusing, or they have, some extenuating circumstance that's going to prevent them and their specific social circumstance from seeking care. Can you talk them into going to the hospital, or, can you sign off on this, right? And so this group of investigators from Yale, they used a data set of high-risk refusals to determine whether calling and speaking to a physician actually modified the probability of transport, right? So the kind of commonplace practice of putting the physician on the phone with the patient, does this actually move the needle? Does this actually convince anybody who's at high risk of having an adverse outcome of coming into the hospital? And interestingly, they found that speaking to a physician did not influence the probability of transport. And so I think that this is an important scaffold for future work, critically examining the role of medical physicians in these consultations, right? How we should be engaging with these patients, right? And so I thought that this was kind of, although it had a null finding, a thought-provoking abstract that forces us to kind of critically consider our own role as medical directors and EMS physicians in mediating transport in these scenarios. So that's all I have. Thank you very much for listening.
Awesome. I would love to have seen in that last paper, because I think that all medical director calls are not created equally. There's a style that's needed there. And I would love, like, nowadays that we're recording all these calls and we can look at AI. I'm sure, just like not all salespeople are as successful. That would be an interesting one. So lots of questions, and there's a lot of questions about Ian's work as well. So let's go to Dr. Lee and Wayne, if you want to ask your question. Wait, before you do that, I'm gonna have to unmute everybody. And just so everybody knows, I do that just so we don't get spammed, because we've been spammed before. So there's nothing personal against anybody. I've been doing that for over a year. But go ahead, you can unmute yourself and show us yourself. There you go, Wayne.
Hi, am I there? There I am.
Yes.
Very quickly, two areas I want to cover very quickly. I have to leave, but I mentioned in the chat just a little bit, but we go to our trauma system meeting, 3 trauma centers, medical examiner. Basically, we're looking at dead patients, and is there any room for improvement? Our medical examiners brought it to our attention. The trauma surgeons tend to agree that the mechanical devices, and I'm just going to say what they're saying, mechanical devices are doing significant damage. So everybody in the trauma arena are asking us to back off on using mechanical devices. And when I say that, I think for the most part, we're talking about Lucas, et cetera, et cetera. Recently, when we went, the medical examiner came to us about a case that we had that was a non-trauma case. And she showed us the pathology, and when asked, and of course, the first answer is, well, this happens with non-mechanical compression, the injuries. But her response to that is that she is 1,000% sure of what she sees is not the same as what she's seeing in non-mechanical compression. So just that item, I just want to put that out there, number one. The other thing is, because we have, in the Seminole tribe, we have these casinos. And so I have high-risk refusals, and I've had them for a number of years. And Peter and I have just encountered one just recently. And I can tell you, I was really surprised at the outcome of that study, because Peter commented on it, but I can tell you this, because we have these casinos, we have a lot of people that are refusing transport, and elderly, alcohol involved, and so on and so forth. And so with those, almost all of those I get called on, and probably about half the time I actually, maybe a little bit more actually, I've gotten the habit. I actually talk to the patient, and I can tell you that my conversion rate is about 50%, maybe a little bit less than that. And actually, years ago, there was a study that looked at this, and it actually looked at, and I can't find it, but I think it was in the annals a long time ago, that they actually looked at this, and they showed that if you just left it at the paramedic level, not that they don't say everything we're going to say, that it was X%. If you actually call the hospital, that changed it. The patient said, "Oh my gosh, they're calling the hospital to get their opinion." If the doctor got on the radio in the hospital, it changed that percentage again. But I have to say, I find that very, very difficult to accept. So I do think that the physician being involved in refusals is a very important item, particularly in high risk, so on and so forth. Anyway, those are my comments.
Let me bring in Dr. Mo Daya. So many of you may know Dr. Daya is a pretty prolific researcher in cardiac arrest. From the northwest of this country, involved in the Rock trial. So Mo, are you there? Can you unmute yourself and answer Dr. Lee's first question?
So the question is, remind me the first question.
It's one about mechanical versus manual CPR, the injuries.
Yeah, well, I think that first of all, there's good data that if you look at there's an autopsy published data that shows that there's more injuries with mechanical CPR. The question is, do they actually improve? What does that mean? And I don't know, and I will tell you that we have seen more injuries between liver lacerations, spleen lacerations, gastric ruptures. So I think it's something to look at. The problem is it's a runaway train right now. Everybody loves the mechanical devices, and so we're trying to hold it back, which is not easy to do. As you know, Seattle King County doesn't use them. At least that was my last discussion with them.
Right. While we have you on the phone, and first of all, thank you so much for joining us. You heard Ian's presentation and Tanner's presentation. Any comments or thoughts on either DSED or any of the other abstracts that we heard about today? Love to hear your thoughts.
No, I think that Ian's was really interesting. It kind of fits with what we first went to, and we need a randomized control trial to confirm what Ian has found. So I think the question is, do you start with AP first? It's a little bit more problematic. It takes a little bit longer, but then if you do go to double sequential, it's much easier to do double sequential because you can then put the AL pads very rapidly. So that's how we do it in our system. But the American Heart has an application out for some research proposals, and hopefully we'll be able to look at this in an RCT soon. I know Ian's working on something similar.
Yeah, and so Ian, I'll let you respond, but I will tell you that we have moved to AP only, probably for a while now, and we've moved DSCD up to the second shock. So I know we're waiting to hear what comes out of the Europeans and Sweden and so forth. But Ian, any comments there?
No, I was just going to say the same thing, Peter. I mean, there's a few ongoing trials that looking slightly different versions of dose VF, so it'll be interesting to see what they say. And we've done the same. We've moved all our land services to AP first, just recently. So like Mo said, we're hopefully gonna start up a trial because there's enough observational data here now that I think we need to look at what we're doing. But a trial would be great to really give us a definitive answer in terms of which one might be superior from an initial shock.
Yeah, it would be nice to look at the CARES data set, if we can split out which agencies are DSCD and AP first versus not. I mean, our Utstein at this agency I'm at today went through the roof. We had a 21.3% neurointact survival in 2025. So I'd be interested to see kind of an aggregate of the data. This is, we only had 61 arrests here this last year, but let me bring in someone who's been asking some good questions and think it's deserving for him to get on. So Jonathan Powell, if you wouldn't mind unmuting yourself, tell everyone who you are, and then we'd love to hear some questions for both Tanner and Ian if you have them.
Hey, thanks, Peter. So my name is Jonathan Powell. I'm a research scientist and epidemiologist over at ImageTrend. I had just a question for Ian, which he answered in the chat, but mostly just about thinking the impact of how we look at the within patient and between shock correlation within the same patient, within shocks that can have an effect on each other and potentially have an impact on that modeling. And so I just wanted to ask, what was the thought process behind that correlation structure? And Ian gave a great answer, so I'd rather not speak for him. But Ian, if you could talk about kind of that thought process, I'd love to hear you share your thoughts.
Yeah, I mean it's a great question. To be honest, I think your comment back in the chat was how we had initially developed this too. So, I think what we don't know is we don't know a whole lot about what that might look like, right? And so we tried to use something that was a little bit more forgiving, because I don't think you want to kind of pigeonhole yourself into one specific correlation structure when I don't think we know that much about it. And it's not something that we've done a lot, because mostly we have independent observations for a lot of the research we've done, right? So it does become a little bit more complicated and something to think about when we have these observations that become non-independent. And so we had initially discussed that we think the exchangeable one was probably a little bit forgiving if we weren't exact. We did try, and I can't remember off the top of my head, it's been a while since I did the analysis for it, but we did try a different structure and found it to be very, very similar, which also made me happy that we weren't seeing wildly different results if we did change that around. So I didn't want to do too much, just kind of exploring around, but we did try to see if there was anything else that might, if there was any evidence that the correlation structure we chose impacted the results significantly, and we didn't find that, which was kind of reassuring as well.
Yeah, thanks for that. And that kind of goes into my question with Tanner. I'm a self-acknowledged sometimes reviewer too, and so I just kind of lean into that. And the reason for that is, the kind of assumptions and the things that we put into our modeling and the methods that we use can a lot of times have an impact on the results that we get, and then those results have a direct impact on the interventions that we plan and what we do to kind of implement the lessons that we're learning with this research. And so, to your point, Ian, we don't really know a ton about the correlation between shocks within a single patient. And to Tanner's point on the DAG that he used, which is great, I love seeing more DAGs used in EMS research. We don't always necessarily know that the nodal pathways that we're using on those DAGs are supported by more than associational research or kind of our own assumptions. And so, for Tanner, I think the work that you did was great, and kind of looking at the impact of those different types of devices, because that likely has some sort of impact. And so my question was mostly about like your modeling choices and your decisions. Sometimes when we use continuous variables and we use a logistic regression, it transforms it over into the logit scale and then transforms it back in order to get an odds ratio. And so sometimes those decisions that we make can impact the eventual results, like your number needed to treat. And so my question was about some of the continuous things that you use, like age, things of that sort. Did y'all assess for that linearity on the logit scale? Because I think if you did, and you maybe use splines or categorizations of those continuous variables, that actually might drop down that number needed to treat and possibly make your results, more impactful in the terms of maybe we don't necessarily need to treat that many to see an observation. And so those are just some of my general thoughts. I'd love to hear your thoughts on that, Tanner, and I just appreciate the chance to talk.
And for those of you that don't know, Jonathan and I have recently tangled. He's been my reviewer too very recently. So
We have a good time.
yeah, so we used, and so kind of to answer the question, so we did assess linearity in the logit graphically to begin with, and so we used three continuous variables, so age, response time, and time to mechanical CPR. So that's from scene arrival to deployment of the device, and roughly all of those do display linearity on that scale. Although, again, and this is under review at PEC right now. That's something that I think would be certainly worth, from even from a methodologic standpoint, if somebody came at us with that in the future to illustrate whether that has any modification on our number needed to treat.
Excellent.
Yeah, appreciate it, y'all. Great chance to talk methods. Thanks for the platform to be able to engage.
Thank you. Great question. So I have some questions. So Ian, this is going to be to you, and then I'll give you both the last word. You just heard Dr. Daya said that more RCTs are needed for things like double sequential AP, etc. We know that your initial study in the New England Journal was published in November of 2022. We saw Tanner just put up one of the abstracts that showed that even in the best quarter, December 2024, only 10% or so of people were using DSED, even though you guys showed a twofold increase in neurointact survival. Given the fact that our current guidelines in the U.S. are not recommending it, given the fact that the the vendors had their prior letters were kind of scared people from using DSED. Do you think that the European data, the RCTs coming out of Europe, will change the guidelines or will change practice so that when we're sitting here exactly at the same time in 2027, we're not looking at a 10% or so of use where we all know that the shockable bucket of patients, the witness shockable bucket, the Utstein group, that's where the money is at, right? And here we are, we have the money group, and people are not using a technique that has been shown in one RCT, and the early results of another RCT out of Sweden that Shell has told us about is like strikingly different. Do we have to wait for another United States RCT that's going to take, 3, 4, 5 years, or not? What say you? Take off your ILCOR and your AHA hat, and I want to hear what you have to say about that.
Fair enough. So before I take them off, just my caveat is that I have all of the hats, and so people will have to take this with a grain of salt. A couple of things. So I think from the guideline, and maybe even from an uptake perspective, what I would say, I'm sure everybody has heard lots of counter arguments to the trial itself. My counter argument that I think to my own trial that I think is legit is that it's a trial of 400 people. And so, confirmatory trials in science are important. And so, I can see that as being the one area where people want to wait. What I think will help in terms of pushing the needle forward, because the guidelines themselves won't change for 5 years, right? So that 5-year cycle is not going to happen. The science is going to move in this area dramatically before that 5-year cycle comes back again. And so I think, there will be opportunity for us to probably drive practice forward before the guidelines are going to change. So one of those will be, I think real world data is important too. And as people do it and people see within their service themselves, oh my God, we made one change and we see a dramatic increase. I think that's important. Not everything can just be about randomized trials. Obviously they're important, but real world data is also important. I think the trials from overseas are going to be the important ones, right? One of the things to consider, though, is they're all slightly different, and so there will be slight variations within them. But like you said, the early data from the trials is really positive, and so I think if we can get, if we have confirmatory trials from there, that's going to really push the science forward. And the other big piece of all of this, in between guideline recommendations, is that at the ILCOR level, we update the science as needed and really on a kind of yearly basis. And so the ILCOR recommendations for this stuff will move long before the AHA and ERC recommendations do, just based on the timelines that happen. So I think there's lots of opportunity for expansion for moving the science forward before the next guidelines. And as we see more and more data come out and more trials come out, I hope that will kind of convince the people that are still a little bit worried about one trial and it just being a single trial, because there are examples throughout the literature of one trial that the subsequent ones weren't supportive, but so far the rest of the data looks pretty supportive as well.
Great answer. Very, very well done politically. I love that. Very good.
Thank you.
Okay, so now I want to end with, I'm going to go to Tanner first and then go back to Ian, but the NAEMSP there's a lot of research, and we kind of saturated people with just some studies today that you can see that this is just the tip of the iceberg. Tanner, make the pitch to everybody on this call and for the thousands of people who are going to watch it later. Why should they come to the NAEMSP next year in Austin, and why should they book their travel today to get this data? Because these papers won't be published, maybe for years. So go ahead and give your pitch, and then I'll go to Ian next.
Sure, yeah, and I talked about this a little bit at the Florida NAEMSP dinner, but this organization has certainly changed my life, right? So it is a phenomenal network of mentors, of clinicians, scientists who are not only enthusiastic about improving the care that we provide to critically ill patients in the pre-hospital setting, but we're also passionate about mentoring and making sure that there is a next generation there to kind of carry on that mission, right? And make sure that in 100 years, we're much further ahead than we are now, right? It is an incredibly welcoming group of people who will bend over backwards to help you if you have questions about statistical analyses or to get a paper published, to get a study off the ground. If you're curious about this career path at all, right, as an EMS physician or as a professional, right? Again, I don't know the exact number, but a large proportion of NEMSP, it's not all physicians, right? There are plenty of paramedics, APPs, anybody who's interested in pre-hospital emergency medicine. There's a place for you at NEMSP. And then of course beyond that, the network of friendships that you'll build and the network of mentors that you'll build, right? It really is a place to get a good idea of what the science of pre-hospital emergency care is going to look like over the next 5 to 10 years. And I think that's at least personally, I think a core part of my mission is to continue to drive forward the standard of science and the amount of science that is brought to these meetings and is kind of conveyed to the people who come. So that would be my
Well,
pitch.
well said. And I'm lobbying. I've started softly lobbying, but I think the P in NAEMSP needs to change to professionals, not physicians, because we're at 30% of the membership is already non-physician. I think we need to get to 50-50. So thank you for all the work you're doing to help get us there. Ian, let's hear your comments.
Yeah, absolutely. I mean, it's gonna be hard to beat. What did Tanner say? It's changed his life, so I'm not sure if I'm gonna be able to beat that. But no, I mean, Tanner said it really well. I think for me, so I've been going to NAEMSP for a while now, and what stands out to me about this conference, and that I think people should consider if they're looking for a conference to go to if you haven't been before. Number one, the networking I think is second to none, for a variety of reasons. I think it's probably where we introduced to each other, Peter, probably back, a number of years ago. But there's so many different relationships that I've formed at NAEMSP, and I really, I enjoy going for those opportunities, and whether it's from a research perspective, a clinical perspective, a professional perspective, there's so many different people that those connections have come through NAEMSP. So I really enjoy it for that piece. The other thing that I think NAEMSP has done really well is I've been over the years more and more and more impressed with the science that gets presented there. One, with the quality and the amount of science, and so looking back 10 years, it's really more from the same people going up all the time and presenting the same research around the same topic that happened many times, and now looking at a whole bunch of different people presenting from all over the place, and the number of different topics, I think, NAEMSP's really done a good job in having a bunch of science for everybody. And it's really got its pulse kind of on where EMS is going, which I think is really important. The other thing that I think they do really well, which is unique and hard, is taking that science, but also making it more of an interactive and kind of it's got a feel to it that it's not just about going up and listening to p-values and odds ratios, and there's more to it than that, right? It really does well speaking to the professional members, and I think paramedics and kind of frontline people would really enjoy that aspect, that you're not going and just listening to a whole bunch of science talks, and there's really quite a bit more to it at NAEMSP, and I think they do a really good job of that. And so for people like my colleagues and paramedics that I know, I think it's a good conference for that, because you're going to get a mix of science and a mix of frontline practical application. I think NAEMSP does a really good job of putting all that together.
Great, very well said. And what I would say is what I've seen them do over the last couple of years is that they have these pre-conference courses that last for 8 months to a year. So you come in, you want to do CQI, you sit in a room with people like Maya Dorset, who's wonderful, and her team, and then you actually go back home and you complete your CQI project. They had a new one this year for pre-hospital research, and I spoke to one of the paramedics, a chief who attended, and he says it was mind-blowing. He said, I already have my project. They gave me, I think, image trends part of it. There's some other people who are helping that person who may not have some statistical knowledge or an EPCR background, and they say, what's your interest? All right, here's your idea. And then over the next 8 months, they're going to actually put together their own project based on their own data. So again, I think the organization has done a wonderful job of coaching, mentoring folks. So it's not just one of these places you go to and you just hear a bunch of boring lectures. Like you're seeing what's into the future of EMS and what's going to be published over the next couple of years. And both of you, and again, I'm going to include people like Dr. Modia, who, we all look up to. We sit in the audience and we say, because now that I have 15 years of seeing it, I hear the abstract, and then my God, years later I see the paper, and then it takes another couple of years to get that integrated into our practice. So we have to shrink that down to not a 15-year cycle to get something like DSCD in practice when the first paper on DSCD was published, or the case report was in 1994. Here we are in 2026. Just think about that, and how long it takes for that to happen. So only 40% of the abstract submissions were accepted. Only 40%. So I think we had three of ours denied. So we got several of ours accepted, but it just shows the caliber of research, like Ian mentioned, is going through here is just insane. So JW Marriott, Austin, January of next year. Look up the calendar. If you're a physician, you ought to be there. If you're a paramedic, you ought to be there. If you're an EMS leader, you ought to be there. And we hope to see you there next year. So great job. Doug Kupis doing a great job as a president, and Kevin Mackey coming in as the next incoming president. Just amazing people at this organization. So, all right, with that, please everyone join over to Dr. Pepe's webinar. I'm going to go head out and hit the streets, and I'm going to see if I can figure out my NNT today with my plunger device. No, I'm just kidding. And but good to see everybody. Thanks for all your questions, and thanks to all of you who joined us. Happy Friday. Have a great weekend. Signing off.
Thanks,
Bye,
Peter.
everybody. You got it. Thank you both.